And any questions?
Only in case I need it. So I'll just I won't put my video on just in case my bandwidth's not that great. So just hello to everybody, and I'm here today to talk about SISTAQUIT. And I'm from the University of Newcastle, and I'm Associate Professor, and I've been working with Aboriginal people around smoking cessation for about 15 years. So I'd just first like to acknowledge I'm on Gumbaynggirr country in Coffs Harbour and pay my respects to elders past, present and future, and all the Aboriginal and Torres Strait Islander people here today. So this is our team. So for both of our projects, for SISTAQUIT and iSISTAQUIT, I'm going to be touching on both projects, and we are mostly from Australia, but also from New Zealand. So just a little bit about why it's important to help pregnant women quit smoking. So we know that smoking is the main risk factor for low birth weight. And improving the birth weight of Aboriginal and Torres Strait Islander babies is one of the new Closing the Gap targets, an important one, because although it's not just birth weight that gets affected by smoking, if the woman smokes during pregnancy, it's also it is a marker for other chronic health problems later on in life. So babies born with low birth weight are more likely to be obese later in life, and also the obesity can lead to diabetes. And we know there's a host of a whole other lot of health problems that can happen. And it's not just affecting the baby, but also obviously mum. And we do know that at the moment, nationally, about 44% of pregnant Aboriginal and Torres Strait Islander women smoke, but there are areas, as Tom, and those areas, the prevalence is slower to fall, and there are some quite high rates also in WA. So Aboriginal and Torres Strait Islander women are actually motivated to stop smoking, but
excuse me, Gillian, you're kind of falling in and out. Are other people experience that?
Yes,
Donna,
Gillian,
can you take over?
Yep. Yeah, just get Gillian to, I think it's a bit delayed.
So on the other side of the spectrum with health providers, that they're
We'll try and get Gillian back on. I know she's been having some problems with her audio, so we'll see how we can fix that, if you bear with us for a minute.
Yeah, I could try. But I haven't got the phone number. Phone number I can try. Okay, I'm going to try my phone. I've patched it through to my internet on my phone, so I'm going to try that. Can you hear me now?
Yes, can hear you now, Gillian.
Much
Yeah.
better. Yeah.
Sorry, I'll just share my screen again.
That's much
So I don't know
better,
where we
Gillian.
got to. Did you get the whole of that bit about, I was talking about the health providers are not confident in providing care for pregnant women. And and we know that actually if we do train health providers, it can double quit rates in general in people who smoke. So we feel it's very important to help pregnant women quit because that helps babies avoid lifelong health problems and also behavioral and learning problems. So I just wanted to show you this survey that we did with health providers. And this is a survey we did with GPs and obstetricians all across Australia. And we asked them how much they often or always did these following things. And what's really interesting is that, you know, generally they're good at asking and advising about smoking cessation, asking about smoking and advising people to quit. But when it comes to doing some other things like actually assisting people to quit or helping people make a quit plan or a quit date, or assisting with NRT, and these are in pregnancy, that, you know, you can see the rates are dropping down successively, and even arranging referral, like something like arranging referral to Quitline, etc. They're only a third of them are doing that. So the other interesting thing is we did a bigger study across the whole world and looked at 10 different countries and what papers have been published, and around a range of health providers, like including doctors and obstetricians, but also midwives, Aboriginal health workers, nurses, etc. And we found almost the identical picture. If I put the other picture up, it would look exactly the same as this. So it's very, very similar. So what's happening in Australia is not unusual. It seems to be a worldwide phenomena that, you know, yes, we might go, yeah, do you smoke? Yes, you should quit. And then that's it. We don't necessarily do the other steps that are needed to actually help people quit smoking. So it was on this basis that we developed our SISTAQUIT project, and we went through different phases. And some of you, I don't think anybody in WA was involved in an earlier phase, but it used to be called I Can Quit in Pregnancy. So we started designing that back in 2016 with some local Aboriginal medical services in Hunter, New England. And then we pre-tested those materials and resources in 3 AMS in 3 different states. And then we went on to phase 2 the following year, which was a study in 6 services in those 3 states. That was Queensland, New South Wales and South Australia, looking at how feasible and acceptable the pilot project was. And then we switched names to SISTAQUIT for phase 3, which is a randomized controlled trial. And I'm going to talk about that a little bit more. And that's in 5 states. And our project coordinator for that is Jolie Foster, who's on the call today with us all. They're waving there. And we're about halfway through that study. And then we did get this wonderful surprise from the Federal Department of Health to fund iSISTAQUIT for phase 4. So I'll let you know where we're up to with that study. But we're already thinking ahead to what our next phase might be, and that would be like a broader, more scale up nationally, and looking at adaptation internationally, because we do have some other countries very interested in what we're doing over here. I don't know if you realize, but Australia really leads the way in this research with Indigenous populations and smoking in pregnancy. And so Canada particularly is looking to us to see what we can offer them in terms of adapting this program to Canadian First Nation women. So that's really exciting. So with the approach we're using an A, B, C, D approach because number one, it's kind of a bit easier to remember. So A is ask and assess. B is doing that brief advice to quit, which, as I mentioned, people are doing quite well already. But the C and the D are very important. So the C is actually helping people quit by using things like behavior change techniques, that which could include counseling and things like that, helping people make a plan to quit, and using nicotine replacement therapy if it's indicated. And then the D is to discuss the family, social and cultural context of smoking and pregnancy. Because as we know, women are not in isolation, hopefully as a pregnant woman, and the whole situation at home is very important and has social and cultural situation. So we do suggest you take that into account. So just a little bit more about, just because there is a bit of a difference between SISTAQUIT and iSISTAQUIT. So SISTAQUIT, as mentioned, is actually what we call a randomized trial. Half of the services will get the intervention and the other half just carry on doing their usual care as the control group. And the actual intervention itself is training. So what we're doing is training the health providers at the services in culturally competent evidence-based care for smoking cessation and pregnancy. And we collect data at the health provider and service level, and also data from the women and their babies. And we follow up the babies to 6 months postpartum. And iSISTAQUIT is a little bit different because it's not a trial like that, but what we're doing is implementing our intervention, which is the training and all the resources we're developing, in 20 more services. And everybody gets the training and the resources. And we collect data still at the health professional and service level, but we're not specifically recruiting women and babies into that study. We're using quite a different way of actually capturing information from children. From the women, sorry. And then additionally, we're developing a social media campaign to go with that. SISTAQUIT, just to give you an update, and I think it's important because we do have one site in WA who are part of the trial, so that's Moronka. In fact, we've got altogether about 7 sites, TIS regional teams altogether. So we've got 23 services were recruited into the trial, and 20 at CHOS and 3 are mainstream. So far, we've recruited about 90 health providers and more than 60 women, and we've got 9 babies in the trial so far have been born. And we have actually had the trial extended now to early 2022 because of the delays with COVID, etc. But I just want to do a bit of a plug for getting data, because so Arthur Conan Doyle, who wrote Sherlock Holmes, and we all know about Sherlock Holmes, said, data, 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 I can't make bricks without clay. So I think, you will all relate to that, because I think, you're all being asked to provide information to do with evaluating your programs. And we do need to ask that our participants are followed up regularly and the services supply the data we need. And now we've actually got higher incentives for health providers being involved by doing their surveys, and everybody gets a bonus for doing a survey. So whether it's the staff who are taking surveys from the women, or the women themselves get money, and the babies get money providing their data. And we will be doing some mid-study interviews soon with some incentives. So now we come to iSISTAQUIT. So we do have Ali Hart on the call today with you all, who is our Aboriginal Research Assistant and Cultural Liaison, and she may have been reaching out to some of your services. Did I quit it? Yeah, sorry, I just flipped over that. So with iSISTAQUIT, we've had well over 40 services express their interest. We've been asked to do half mainstream services and half ACCHOs. And we've got a good balance. So we've got 25 services already ready to sign up, and we're starting to get a wait list, because we know even though people say they're going to sign up, sometimes things happen, circumstances change. So we're happy to have a waiting list, and it's about half Aboriginal services and half mainstream. We do have services in WA interested, and I think you probably know if you've actually been having conversations with Ali, and we also have some mainstream services interested in Perth. So all sites will get the training, a carbon monoxide meter, and oral forms of NRT, and the resources to give women. And we've now developed like a self-paced e-learning modules to make it really easy. And those e-learning modules can be done either on a laptop, on your mobile phone, or an iPad. So you can chunk it down, do a little bit, 20 minutes here and there, and, get that completed. Overall, it takes around about 4 hours to go through that whole e-learning. We've also developed we're in the process of developing some templates for your medical software. So that's whether you use Communicare, Medical Director, etc. Health providers will be able to go on and just tap in all the information about their patient, keep up to the plan with what they're supposed to do with the ABCD, so it reminds them. And that way we can collect de-identified data from the women who will all be grouped together, and we'll get a report from those software programs. And if you are interested, we're still interested in hearing from you. Ali would like to hear from you, and that's our email. So it may be we can still include you. This is a little bit about the resources for iSISTAQUIT, as I've mentioned, but just to show them visually. So the little snaky design here is part of our e-learning. So you will get an idea of how to pace yourself through all of those components and how far you've got. And there's some kind of quizzes and evaluation tasks as you go that are it's very interactive. And we've got an educational panel who are mostly Aboriginal people from the health professional colleges, like the Aboriginal Health Worker College and Katsanam, and the obstetrician and GP colleges. That we've had lots of very positive feedback. People really find it useful and interesting to do. And then the women will get a booklet. So at the top right here, we've got the example of the booklet with some colouring in pages for the women. And they've got little videos in the booklet they can watch by just clicking on a QR code. And then, the health providers get a treatment manual with more detail in that. So we are developing this media campaign, and where we will hopefully be on track to launch it at the end of the year. To inform that, we did this review of all of the literature that might inform that's been published, privileging Aboriginal women's voices. So we read all the papers that, mostly qualitative, where women said what they felt they needed to help them quit in pregnancy. And we analysed that, and then we looked at a whole lot of campaigns, about 17 different campaigns, and resources that are already out there for Aboriginal women in pregnancy. And you might be surprised there's that many, but some of them go a bit back to, a few years ago. And we're looking at, are there any gaps? Are there any opportunities for fresh messages that haven't perhaps been explained before. And we're going to be working with Galimba, which is a creative company, to film in 4 or 5 locations nationally, if we can get out to those locations due to COVID. So if there is a site in WA that's interested in us coming in and filming, let us know. And we've got a really good social media panel ready to meet and help us with that task as well, which are mostly Aboriginal people and Torres Strait Islander people on the panel. And when we've got our films done, they'll be going out through Facebook and Instagram, the usual sort of social media channels. And the TIS teams will have access to those. So if you want to have those on your Facebook sites, etc., you know, that'd be fine. So that's just the end of what I had to say about that. And I just want to plug a couple of other studies we're doing. So I work with also Dr. Michelle Bovell, who's an Aboriginal postdoc research fellow. And she is doing a study called Which Way? And she's very interested in looking at, you know, there's still a lot more to be known about what Aboriginal women might want to help them quit smoking, and particularly perhaps methods that don't use medication. And she's got a survey live at the moment, and she's had about 300 replies, but mostly from New South Wales and Queensland. She would love to have some input from WA. And that's her link. You know, we're happy for you to have these slides, and that's her link to the survey and her Facebook site. No, I think that's just to the survey, but she is on Facebook as well. So it's only a 5-minute survey, and there's prize draws. So please think about doing that and getting that out to your, you know, people that you might know in your communities. And then also, just one last thing is Tabassum Rahman, who's a PhD student of mine, who's on the call also today, is also doing a project that she hopes to directly involve TIS coordinators in. And you might have seen a diagram a bit like this before, because I know Penny has talked to you about more of the social ecological model and how that fits in with your population health approach. So, you know, when we're looking at interventions, you know, we can do those interventions on an individual basis, family, community, or system level. So that kind of fits in with probably a little bit what you know already. What Tabassum would like to do, she wants to see where some of the barriers are at those higher levels. So, she's very interested to talk to TIS team coordinators, because you're the ones that are working closely with your community, and you know what, you know, you would have be a wealth of information about this. So she's looking to organise some one-on-one discussions with you as part of her research, and Desley's helping us organise that with whoever might be interested, to just talk about your take on all of these different levels of barriers and enablers. So more from Tabassum in due course. You'll hear more about that later. So I'm happy to take, I'm going to stop sharing my screen now, and I'm going to give you a little wave, because I didn't want to risk putting my camera on before, so in case I dropped out. But it's great being with you today, and if you have any questions or want anything from us, just, you know, happy for you to have the slides and reach out. Thanks.
Thanks, Gillian. I do have a question, and it comes from the Wheatbelt team. They've asked, what are the key messages we should be talking about, cut down versus quit, when talking with community midwives, nurses, grandmother, liaison officers who work directly with pregnant women? They often ask, assist, but find it difficult to encourage referrals, etc. Also, is the e-learning and social media resources only available for those organisations participating in iSISTAQUIT? Now, that's a big question. So you can see that in chat if you want to answer those?
Yeah, well, first of all, I think it is very important what we tell women and to have a sort of consistent messages, because women are telling us they're being told all sorts of things. And, you know, even from doctors are still saying to some women, it's too stressful for your baby for you to quit smoking. So, you know, we do have to get our messages consistent. And what we like to go for is quitting, not just cutting down. Because we know if women still smoke, and even if they only smoke 1 or 2 or 3 a day, that still has effect on the baby. So the only way that woman can be safe for herself and for her baby to be safe is to completely quit smoking. Now, you know, when that person is able to have a more in-depth conversation with a health provider, it may be if you get her onto nicotine replacement therapy, you can ease her into quitting over a few days, you know, with a little bit of a stepwise approach, but it is with an aim of coming off completely. So we know that when people cut down, when they smoke, they inhale it deeper, and they can still have the same levels in the bloodstream of nicotine, etc., and tobacco toxins, because they're trying to suck the life out of every smoke they have. So it is important to say, look, the best way you can get a good outcome for you and your baby is to quit completely, and we can help you, support you to do that. So you're not on your own. You know, the people who can support you hopefully will be the health professionals and their service, but also don't forget the quit line. So, you know, you can help a woman ring the quit line, or you can do a referral with the woman so she gets referred and the quit line will ring her, and facilitate, even that, stay on the call for that first session with the quit line to break the ice. So women do need help, and they do need support, and they do need follow-up, and they need encouragement, but women do it. They can do it, and they have done it. So as regards signing up for iSISTAQUIT, yeah, we're wanting a whole of service approach for the very reason I'm mentioning, is so that, you know, if only one person does the training and the service and then everybody else is giving mixed messages, it can get confusing for the woman. So ideally we do want, if you know, services to sign up, and then the training is available to everyone. We are looking ahead to the future where we can say anybody in Australia can do the training. We're not quite there yet. So I think talking to your liaison officers is just, you know, if your service came on board, then we'd be happy for community midwives to come in. You know, we'd be happy for some community liaison and grandmas to come in, you know, and do the training. You know, so like, we're not going to be exclusive. It can go out to the border area where your service is located. So we're open to that. Any other way that we can be a source of advice and support for other questions you might have, we're really happy to be contacted. We're happy to come and arrange a talk to your local service or your local area. You know, one of our team are happy to link in with you just to give you a bit of support. So do reach out.
Thank you, Gillian. We're really moving along very well today. So we've still got time for any other questions, a couple of more questions, if you have them. If not, let's go to, Desby.
Yeah, thanks, Max. Just wanted to ask, Bassam, when you're talking to the coordinators, will that be half an hour? Will it be surveys or just interviews?
Now we're looking at half an hour to 35 minutes to the max.
So yeah, that's the point, you know, that everyone is busy and everyone is time poor, so we don't want to overburden anyone with any further things. Just another thing on that site. So we are really looking to do it as quickly as we can. So it can, at the best, it would be 35 minutes.
That was around 35 minutes interviews. Okay, thank you for that.
We couldn't hear that. We couldn't hear that. Sorry. I think a few of us couldn't hear it.
Okay. Would you like to just give that answer again? Thanks, Tabassum.
No.
Yeah. So I think Tabassum's saying that it's about half an hour basically. Yeah, and it'll be mostly a discussion. There will be maybe some questions just about your demographics, you know. Sorry.
Great, thanks.
Yeah, sorry. And just about the social media, that will be available to everybody in Australia, because we'll be putting that out on, you know, all the social media channels. And if you want to, anybody wants to put that on their Facebook or Instagram, we'll have that available to disseminate. Yeah.
Excellent. Thank you for that. If no one else has got any questions, Ben's going to pop up in the chat the link for the evaluation, and if you want